Hi, and welcome to my study space. My study space. Anyway, this is just like a quick summary of endocrinology because I just want tidbits for myself to remind me much later when I need these notes. So number one, hyperprolactinemia. Just bear in mind, this is excess production of prolactin from the anterior pituitary gland. And remember that it's similar, right, in structure to TRH for later. So physiological causes of why you might have hyperprolactinemia could be like pregnancy, PRL, which is prolactin. It increases throughout your pregnancy and it reaches its peak at delivery. Also, during breastfeeding with nipple stimulation, you produce more PRL. Physical exertion, stress, which is both physical or psychological, because I've just said physical exertion before. Sleep also, the levels apparently they peak between 4 a.m. and 7 a.m. Not sure about some of us who are night owls, what time they peak. Also meals or during seizures they peak. And the normal lab values for prolactin is like 20 nanograms per milliliter. Pathological causes of hyperprolactinemia could be estrogen induced. Sometimes chronic renal failure can do that. Hypothyroidism. But obviously, mostly we are talking about a prolactinoma, which will be the tumor in there. And so the hypothyroidism that I mentioned is primary. Renal failure, acromegaly, apparently it does cause secrete growth hormone and PRL. And then severe liver failure, infiltrative disorders, or CNS masses, because these masses will be in the sella tussica. So could be from within, from the prolactinoma, or from outside, from that little squishy place, right? Low levels of thyroid hormones, they will cause like your compensatory increase in the TRH, which is also like a PRL releasing hormone. Head trauma, surgery, chest wall trauma. So apparently with the chest wall trauma, it involves the reflex suckling arc. Drugs that are mostly that induce hyperprolactinemia. We talk about your antidepressants and the antipsychotics, like the neuroleptics, SSRIs, like the fluoxetine, the MOIs or the MAOs, the monoamine oxidase inhibitors. Methyl dopa is one to look out for. The dopamine antagonists, so for instance, like your haloperidol. I mean, we don't really use that much these days, right? Hope so. And then what are the clinical signs that you'll be looking for in a hyperprolactinemia? So we think of like, hypogonadism, infertility, galactorrhea, amenorrhea, and decreased libido. Large tumors can present with headaches and visual problems. So when we talk about large, we talk about now expanding up to the point where they can impinge on the optic chiasm, or maybe if there are tumors that are external from the pituitary gland itself, they can also cause that. I'm just reading some questions here. These are the many cases. So what are the indicated lab tests for hyperprolactinemia and why? So you might be thinking, okay, if you're suspecting a hyperprolactinemia, you want to check the TSH and also the prolactin levels. If TSH is high and then the PRL is normal, then go down the route of thyroid disease. And then also after that, you want to check, you want to do your MRI, obviously, to check for a prolactinoma. And then you might want to do your visual field tests, blah, 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 or pregnancy testing, Hook effect. What is the hook effect? So this one is very common in hyperprolactinemia as well. This hook effect is like a fall in the diagnosis of this condition. So you need to have caution when you are interpreting these levels, especially between the 20, we said the 20 was the norm, right, and the 200. So they say that in the presence of like a macroadenoma, because of the possible artificially low values due to the hook effect. So this effect occurs when a very high serum prolactin, for instance 5,000, right, it can saturate both the capture and the signal antibodies used in your immunoradio metric and the chemiluminescent assays, so they can then prevent in the binding of the two, like in a sandwich. There's really good visuals of the hook effect. Just Google that. Common findings for hyperprolactinemia on imaging. Obviously, we said the MRI is our study of choice to identify or to confirm any pituitary masses. So microadenoma, we are talking less than 1 centimeter, and then macro, it's more than 1 centimeter or 10 millimeters. Differential diagnosis for hyperprolactinemia, you want to think about like primary hypothyroidism, adrenal insufficiency, macroprolactinemia, that's the hyperprolactinemia, right? Chronic renal disease, liver disease, medications, and apparently idiopathic is a possibility too. Discuss the treatment options for a patient with symptomatic pituitary microadenoma. Treatment options for prolactinemia: please don't rush for surgery. First line here is a dopamine agonist, because remember the prolactin, dopamine, the pathway, again, look at the diagram. Prolactin is inhibitory, or dopamine is inhibitory to prolactin. So if you are in producing too much prolactin, you want an agonist, not an antagonist. Okay, and so our two dopamine agonists that we're talking about, cabergoline and bromocriptine. Cabergoline and bromocriptine. Take home messages before I stop hyperprolactinemia. Just know that the causes could be medication, could be hypothyroidism, could be chronic kidney disease. Also just know that PRL is renally excreted, so that's where the kidney disease comes in. What else? Increased prolactin, primary hypothyroidism. First, yeah. Also, a hypothyroidism is more common than hyperprolactinemia. So every time you want to rule out hypothyroidism due to cross signaling between TRH and the dopamine signaling. So just bear that in mind. Hypothyroidism is more common. So when somebody comes or presents with symptoms that you might be thinking hyperprolactinemia, rule out hypothyroidism. Thank you.